Okay. Pleasant good evening to all of you. Today is our session on migraine masterclass. This era is the era for migraine because we have a lot of understanding on the molecular pathology of migraine. Today, we'll be discussing about two special sessions. One is about vestibular migraine. It's a much debated entity. Sometimes when we see a patient with headache and vertiginous sensation, we most of the times we end up referring to the ENT physicians because the pathophysiology of vestibular migraine is not very well understood. It is known by different names: migraine with vertiginous aura, migraine with brainstem aura. Today we have an expert with us, Miss Maria Macala. She has experience in neurootology and neurological disorders as well. So she is from Colorado. She is working in the Colorado clinic in association with the ENT physicians. So she has vast experience in seeing, evaluating, and managing patients with vestibular disorders, Meniere's disease, other neurootological disorders. And she has special interest in migraine, especially vestibular migraine. So she will be our first speaker. She will introduce you the term of vestibular migraine, the pathophysiology of it. And because she has direct communication and she takes in detailed history and she knows very well what the patient is suffering from, how to evaluate the vestibular component of the headache or otherwise, how to differentiate between vestibular migraine and other vestibular disorders. So she will be speaking about those things. So anybody who has a doubt regarding how to deal with these disorders, you are open to ask question to Ms. Maria Machala. So it's my pleasure to introduce our first speaker, Ms. Maria Macala. Ms. Maria, the floor is yours, please.
Thank you so much. Thank you. It really is an honor to be here today. So thank you to IVPN for having me. So yes, I'm a nurse practitioner. So a little background, I know that's a role unique to the United States and a few other countries around the world, but the nurse practitioner profession was created in the 50s for a shortage of primary care providers. And so really the goal is to fill in any gaps in healthcare. And so of course it's always changing with how much the healthcare field is changing. But one of my passions is treating dizzy patients. You know, it kind of does fall in between both the neurology and the ENT specialties. So that's where advanced practice providers, nurse practitioners, and physician assistants can really help out. All right, so I'm going to cover a little bit of the pathophysiology, which is, you know, unknown in vestibular migraine. We have some ideas, and then also how to diagnose these patients and effective treatments. So vestibular migraine, really the symptoms were first described in the Huangdi Neijing, it's the Chinese medicine, some of the earliest writings there, and then by Areteus of Cappadocia, well-known Greek physicians. So they described these disorders of episodic vertigo with ringing in the ears and headache, visual changes. There are a lot of different terms that we use or that have been used, like migraine-associated vertigo. The term vestibular migraine was first introduced in the early 1900s, and that's what we use now. That's, you know, the official term. So it is a very, very common cause, if not the most common cause of episodic vertigo. So BPPV is the other one. You know, I would say in practice, I tend to see vestibular migraine just as much, if not more, than BPPV, and then a lot of the other inner ear disorder causes of dizziness.
Excuse me, Ms. Maria, could you please share your screen?
Oh, yes, I'm so sorry. Thought it was already done. Okay. Can you see it?
Yeah, that's it. We can see it.
Perfect.
Thank you.
Okay, yeah, sorry about that. Okay, so yes, it affects up to 2.7% of the population. Like I said, the most common cause of episodic or spontaneous vertigo up there with BPPV or benign paroxysmal positional vertigo. It is, even though it is the most common or one of the most common causes, it is under-recognized, so under-diagnosed and under-treated, unfortunately. Okay, so let's go over a little bit of the anatomy and the physiology of the inner ear. So we have the 3 semicircular canals, and then we have the utricle and the saccule. So that makes up the vestibular part of the inner ear. The cochlea here is for hearing. So the 3 semicircular canals detect rotation in all the different planes. And then the utricle and the saccule, think of them as like gravity sensors. So they detect, you know, where your head is in relation to gravity, as well as any kind of linear movement. So the inner ear will send signals to the brain via the 8th cranial nerve, which is the vestibulocochlear nerve. So the end cells are the hair cells, and they have these little hair-like projections called cilia. Those cilia move with the fluid movement of the inner ear, with any kind of head movement. And the movement causes excitation or inhibition depending on the direction. And that's what will send those signals via the auditory or the vestibulocochlear nerve. And then we'll go on to the central pathways here. So from the 8th cranial nerve, it goes to the vestibular nuclei within the pons, at the pons and medulla junction, in the brainstem. And that is also where we receive visual and proprioceptive input. Okay, so the brain uses all of these, so visual input, and then proprioceptive and tactile input. So if you think of the stretch of the muscles and pressure on the footbed, things like that, that tells us where we are in space. Okay, and then from there we have projections into the cerebellum mainly, but also the cerebral cortex. And then the efferent pathways, so strong connection between the inner ear and the eye muscles. So especially with the semicircular canals, that's what enables us to keep focus when our head is moving. So gaze stabilization or the vestibulo-ocular reflex. And then postural, and that is closely connected to the utricle and the saccule. So, so our gravity sensors and keeping our body upright. So what do we think is going on with vestibular migraine? Probably similar to that of migraine headaches and a lot of the other migraine symptoms. So sensitization and activation of the trigeminal-vascular system. So the trigeminal nerve, the 5th cranial nerve, the largest one, it innervates the face, mainly sensory input. And so when this is activated, there's a release of these inflammatory peptides. These are just a couple of them: substance P for pain, CGRP, serotonin, one of the neurotransmitters involved. And these are all involved in pain, so nociception, and then also they activate the vestibular cortices. The trigeminal nerve also innervates the inner ear, which is interesting. And so that's why, you know, we might get some of those peripheral symptoms in migraine. So you can actually have hearing loss and loss of balance function in the inner ear with migraines on occasion. And then also these receptors, so the CGRP receptors and others are found in the inner ear and might have to do with fluid balance. So we know there's this connection between Meniere's disease and migraine, and this might be one of the reasons why, but again, not fully understood. So key points here: the central vestibular pathways are really complex. They go to, you know, many different parts of the brain, so different areas can be affected, and that's why patients will get all different kinds of symptoms. So it can be a spinning sensation, just more of a vague sense of disequilibrium. And then because you can have multiple different areas of the brain affected at the same time, you can get a lot of different symptoms in addition to the dizziness. So it makes it really challenging to diagnose. So simplified, this is how I explain it to my patients. You have this, this brain hypersensitivity, so that trigeminal vascular system is activated a little too easily, usually genetic, and then you get this perfect storm of triggers, which we'll talk about in a little bit, and then it causes, like I said, that activation and release of those inflammatory peptides. All right, so here are the criteria. This is the Berenice Society, the International Vestibular Society, and the International Classification of Headache Disorders. So to have vestibular migraine, you need to have at least 5 episodes of these vestibular symptoms, moderate to severe intensity, lasting 5 minutes to 72 hours. Usually there is some current or previous history of migraine headaches, can be with or without aura, and then also 1 or more of the typical migraine features with at least half of the episodes. So headache with at least 2 of the following: the one-sided location, pulsating, moderate to severe pain, and then aggravation by routine physical activity, light and sound sensitivity, and then visual aura. So you need to have at least 1 of those with at least half the episodes, and then not accounted for by another vestibular diagnosis. And then probable vestibular migraine, which I would say is far more common. Only 1 of the criteria of B and C. So they might not have a history of migraine, or they do have migraine, but they don't necessarily have those other migraine features with the episodes. Okay, so this can be really difficult to diagnose. Like I said, there can be many, many different symptoms. There are many different causes of dizziness. And then there's a lack of objective findings. So usually the exam is normal, testing is normal, which we'll get to in a little bit. And then you can also have other disorders. So it kind of clouds the picture, like Meniere's disease. There's a much higher incidence of migraine in patients with Meniere's disease. And a lot of patients with Meniere's disease will have vestibular migraine as well. And then lack of evidence-based treatments, which we're going to get to in a little bit here. A lot of what we do is extrapolated from migraine headache studies. So a lot of people make the mistake of confusing vestibular migraine with aura, but aura by definition only lasts 5 to 60 minutes and is always followed by the migraine headache. But it's different than the brainstem migraine. You have to have 2 additional posterior circulatory symptoms. And typically with vestibular migraine, they're lasting, I would say, seconds to days at a time. And then there was a study looking at vestibular migraine. Is the criteria too restrictive? And I would agree that yes. In practice, it's not very common to see patients who fit that that definite diagnostic criteria. So it's usually probable. Like I said, symptoms will often last seconds at a time, so not necessarily 5 minutes. And then you can also see a chronic daily dizziness in addition to the little episodes, so that it kind of clouds it a little bit when you put that 72-hour limit. And then a lot of times patients are unclear about their own history of migraine. It's interesting, I'll ask a patient, do you have a history of migraine? And they'll say no. And then I ask, have you ever had a migraine? And they'll say, yes, well, it was years ago and I used to get them all the time. So yes, they have that, you know, the genetic predisposition to have this and all that, but they don't, you know, they don't, because they're not experiencing migraine headaches, they don't think it's related at all. So really important to get a good history about whether or not they've ever had a migraine headache. So there is a lot of symptom overlap. Like I said, Meniere's disease. So Meniere's disease is, you can think of it like an inner ear swelling or distension of that endolymph within the inner ear, and it causes episodes of prolonged vertigo, hearing loss and ringing in the ear, tinnitus, and then pressure in the ear. And over time, it will cause actually permanent damage to the hearing, to the balance of that affected ear. And so there's a lot of talk now is Meniere's disease a form of migraine? So like I said before, the trigeminal nerve innervates the inner ear. A lot of those neuroreceptors are in the inner ear and kind of deal with the fluid balance. A lot of the triggers are the same. And then again, a lot of patients with Meniere's disease also have a history of migraine. A lot of the triggers are the same. And a lot of times you can get these purely Meniere's episodes, fit criteria, along with the migraine symptoms like light and sound sensitivity and sometimes a headache as well. And then 3PD, this is persistent postural perceptual dizziness. So this is the term that we use now. It was formerly subjective dizziness, but now we have better understanding. It's actually like a brain processing disorder. So you have the input from the inner ear, the eyes, proprioception, but the brain isn't processing that information correctly. And that is often triggered by a true form of vertigo, spinning vertigo. So anything like Meniere's disease, benign paroxysmal positional vertigo, vestibular migraine. And then it leads to this chronic feeling of dizziness. And that's often seen in vestibular migraine, which can, again, make it a little confusing because the patients have chronic daily dizziness in addition to these little episodes of vertigo. Mal de débarquement, that's disembarkment syndrome as well. The feeling like you're still moving, usually after getting off of a boat or a long airplane ride, long car ride, and it can last for months or even years at a time. Post-concussion syndrome, you can have headaches that are very similar to migraine or even trigger migraine headaches, same thing with dizziness. BPPV, benign paroxysmal positional vertigo, that's where you have the little inner ear crystals, the calcium carbonate crystals that will get out of place. They're supposed to be in utricle, saccule, get out of place and go into the semicircular canals. And that causes vertigo just with laying down, turning over in bed typically. So different than the spontaneous vertigo that we see with migraine or vestibular migraine. However, there is possibly an increased incidence of BPPV in patients with migraine. And sometimes migraine, you can have positional symptoms. So important to differentiate between the two. With BPPV, we can diagnose that with the Dix-Hallpike maneuver. Superior semicircular canal dehiscence, kind of a lesser known, a rare type of dizziness. That's dizziness caused by a change in pressure in the middle ear, so coughing, sneezing, things like that, and also loud sounds. And what SCCD is missing bone over one of the semicircular canals in the inner ear. So our surgeons typically won't operate on SCD patients unless their migraines are managed well. A lot of patients with this condition also have migraine, and so the symptoms can kind of overlap there. You can get this phonophobia or noise sensitivity with vestibular migraine, which is pretty similar to the noise-induced dizziness that we see in this condition. So, and then, you know, we do worry about some of the rarer central nervous system causes of dizziness, multiple sclerosis, cerebellar ataxia, stroke, and things like that. So these patients, this can be a really, really difficult set of symptoms. Migraine itself is a risk factor for anxiety and depression. And then dizziness is also a separate risk factor for anxiety and depression. And then because this is so challenging to diagnose, it's not well known, kind of falls in between the different specialties. A lot of times these patients are taking a long time to get diagnosed. And so the diagnosis uncertainty can also cause anxiety and depression. And I do see that a lot. It really can take years to get the proper diagnosis and treatment. I had the pleasure of speaking with, she's a nurse as well as a vestibular patient, Lindsay Masegwa, a few days ago. And you can see here, she provides these lectures to different healthcare specialists about vestibular migraine. And she shares her personal story. And you can see she's seen numerous specialists. And it took quite a long time to get the actual diagnosis. So very, very challenging for these patients. All right, so the most important tool in assessing these patients is getting a good history. And because of that anxiety, depression, the numerous specialists, the lack of great treatment, it is very important to listen to these patients with compassion and really hear their story, because that's what's going to clue you into the diagnosis. Typically, these patients have a normal neurologic and vestibular exam. Typically, they will have a normal VNG, or the video nystagmography, the vestibular testing that we do. Sometimes we see these exaggerated response to caloric stimulation of the inner ear. Sometimes they do have some positional nystagmus, but essentially the VNG is going to be normal, unless, of course, they have other diagnoses as well. And typically the MRI is going to be normal. We do see white matter hyperintensities. That's a common finding in patients with migraine. Okay, so if a patient does have an abnormal neurologic exam, vestibular exam, the vestibular testing or imaging does not necessarily mean they don't have vestibular migraine. They might have something like Meniere's disease. You can have BPPV and vestibular migraine. So just because we have an abnormal finding like a weaker ear on the VNG, one ear has vestibular loss, does not mean they're not experiencing vestibular migraine. You can have a vestibular loss from years ago. You can have something like a virus or something like that that will knock out the balance function. But what do their symptoms fit with? So you have to look at the diagnostic criteria and again, listen to the history. All right, so moving on to treatment. Who is treating these patients? Usually it's a mix of ENT, particularly neurologists or those who specialize in hearing and balance, neurologists, and then primary care. When do we initiate treatment? Really, I go by what the patient is experiencing. If they are having these very frequent, very severe episodes, I will be a lot more aggressive than somebody who's having episodes on occasion that they can kind of treat symptomatically. What we'll get to in a little bit is preventative treatment versus abortive treatment. There's not great abortive treatment for vestibular migraine like there is for migraine headache. And so with migraine headache, to initiate prophylaxis, you have to have these frequent migraine headaches. I will initiate preventative medication for vestibular migraine a lot sooner because we don't have that great abortive treatment. And then, like I said, it's rare for patients to come in with this definite picture of vestibular migraine. I will treat probable and even possible migraine. So when I say possible, I mean, they don't really fit that criteria that I explained before, but they have no evidence of any other inner ear disorder, and other central causes have been ruled out. So they might have really unusual symptoms. Again, dizziness lasting for just seconds at a time instead of the 5 minutes, no personal history of migraine, no family history of migraine, maybe no light sensitivity, sound sensitivity, headaches, or anything, but we really have no other plausible cause for their symptoms. And so I'll go ahead and initiate treatment, and it's really interesting to see how many of these patients respond to migraine medication. And so I think that's a really important key. When I see patients who have seen a lot of other specialists and providers, is they don't fit the criteria, and so they're nervous about missing another diagnosis. But really, when you've exhausted all the testing and you know that there's really nothing else going on, then go ahead and treat these patients. Okay. So treatment, a lot of it is the same as treating migraine headaches. So trigger avoidance is very important. Usually it's a combination of triggers that will give rise to these episodes. So it might not be one trigger all the time. Sometimes the patient will be able to, eat chocolate and nothing happens. But when you combine the chocolate with the change in weather or stress, then you can have an episode. So it is important to know, to be familiar with the triggers, dietary changes. There are supplements that we'll get to, the medication, neuromodulation, and physical therapy. So these are the common triggers. I definitely focus on stress and sleep disturbances. I think those are two of the main ones. Some of these are the ones you can't really avoid, like weather changes. You can always control the environment that you're going to be in. But when patients know that these things might happen, they can preemptively treat. So it is important. Dietary triggers are also very important. I do not like for my patients to necessarily do a very, very strict diet. Sometimes that can cause stress, right? It's hard to control your diet all of the time, socializing, going out to eat, things like that. And sometimes focusing so much on diet, like I said, you're going to cause a lot of stress, and then you can miss a lot of nutrients that you actually need. So some of the common groups, I'll have them cut out, like MSG, that's one of the main ones I'll have patients cut out right away, tyramine, nitrates. And you want to cut them out for at least a month or so at a time, and then you can slowly add things back in and see if it makes a difference. Not everybody has the same trigger, so you don't want someone to be super restrictive when it might not be a trigger of theirs. This is where keeping journals can help. But again, you don't want the patient to be so fixated on it, because some of these things are so hard to control, and that can cause a lot of anxiety and stress. Here are the supplements. So this is the American Headache Society and the American Academy of Neurology 2012. In my practice, we use the top 3 the most, just because of the level of evidence, the efficacy, fewer side effects, especially compared to the feverfew and Butterbur. And a lot of patients do really well on these. No, not many concerns. Magnesium can cause some stomach upset, diarrhea, and so a lot of times we'll have to start on a lower dose or try different formulations. But typically these are tolerated really well, and they do seem very effective. So if a patient, if they're not really ready to start a preventative medication, or their symptoms aren't happening as frequently enough to warrant that, then I will definitely just start on these with trigger avoidance. Here are a list of the medications. This is a review done by Smith, published last year. You can see on the left side, these are likely effective. I will use all of these really, aside from Depakote at the very bottom there, this sodium valproate, just because that one is teratogenic, and so we want to avoid that in women of childbearing age, which a lot of these patients are. But otherwise, these are all great medications. They do seem to be effective. And then interestingly, likely ineffective nortriptyline, even though it works very similar to amitriptyline. The study showed that it wasn't as effective. I will use it on occasion, especially if the amitriptyline is kind of working, but a little too sedating. Nortriptyline is less sedating. And then Botox and CGRP inhibitors, there aren't a ton of studies on these, so we don't really know. I was just at the headache symposium this last weekend, so the American Headache Society, and I did my own personal poll of a lot of the neurologists there to see how they treat their dizzy patients, because again, there's not great evidence out there for vestibular migraine, not a ton of studies. The studies that we do have are usually small, so lower quality. And it was interesting to hear how many of the providers do see improvement in their dizzy patients with Botox and the CGRP inhibitors. And then also I had some who use cyproheptadine, which is an antihistamine, using that as a preventative. We know that this is effective in children. We don't really see it in adults, but some of them are using it in everybody, and they seem happy with it. So I think the important takeaway here is you can try a lot of these different things. And if none of the ones on the left are working, then go ahead and try some of these other ones that haven't been studied very much, because we know they can be effective in migraine headaches. And if it's really the last resort for your patient, I think it's worth trying. There are some safety concerns that we think about with these medications. So antidepressants, if you're on, a couple of them, or if you're on triptans too, then we worry about serotonin syndrome. Fortunately, this is very rare. And usually the doses that we need for antidepressants are a lot lower than what would cause serotonin syndrome. For propranolol, it is a beta blocker. You want to avoid it in patients with asthma or severe hypotension. I will still use this in patients who have normal or even blood pressure that typically runs low. Again, these doses are lower. I typically don't see problems with hypotension on this, but you want to educate the patient, and if they can, have them check their blood pressure at home. With topiramate and acetazolamide, there is an increased risk of kidney stones. If they have a history of kidney stones, I might not use it as first choice, but it's not a contraindication. You just want to educate the patient, make sure they're drinking lots of water, avoiding things like grapefruit juice. And then valproic acid, like I said, it's teratogenic, so you want to avoid it in women of childbearing age unless you do have strict precautions and education. But there are so many other medications that you can use. So then how do you choose the medication? We don't have a set guideline on how to do this. Sometimes it's just picking one randomly and seeing how the patient responds. But if they have any underlying conditions, you can kind of go off that. So patients who don't sleep well, who have insomnia, amitriptyline is sedating. They do take it at night. So that's my go-to for that. A lot of patients have anxiety and depression, like I said before. And so we have, multiple antidepressants that can help. Propranolol actually helps with those, the physical symptoms of anxiety. So it can slow the heart rate and the breathing, which can be helpful. If the patient is overweight and they're concerned about the possible weight gain with some of the antidepressants, topiramate can actually reduce appetite and help with weight loss. If the patient is underweight, venlafaxine can help with that. And it's also effective in perimenopausal women experiencing hot flashes. Another key point that I like to educate my patients on is that patients with migraine tend to be a little more sensitive to side effects of medications. Again, it's a brain hypersensitivity issue. And so a lot of patients right off the bat are nervous about starting a medication. So I explain that that's very common. It's okay. We can still use the medication. We start at a super low dose, so lower than a typical starting dose, usually like half. You start really low and you can go really slowly as you need to. And then, side effects, well, they can happen. It doesn't necessarily mean that it's dangerous or that it's not going to work. So a lot of patients, they're nervous as soon as they start experiencing side effects. They're concerned, it's a safety issue. So really good education about that. And that a lot of the side effects will decrease over time. And then they'll start noticing improvement once they get up to the correct dose. Medication adherence is a big problem in migraine. So I think spending some time educating these patients about this is very important. And then also about how long it's going to take. It might take 4 weeks to get up to the normal dose. So that's already a month where they might not notice any improvement. You're getting up to that target dose, and then you want to give it about 4 to 6 weeks after that to see if it's going to be effective. So I tell patients, let's just plan about a 2-month trial for each medication. And then if it's not effective, you can go ahead and start another medication and wean off the initial one. Or if it's partially effective, you can try and add on a different medication. So board of medication, like I alluded to before, just unfortunately not a lot of great options for vestibular migraine. Antihistamines like meclizine are often used, or benzodiazepines like diazepam. I think these can be effective, especially when the patient is experiencing like a true vertigo, so a real spinning sensation, because it suppresses that vestibular system and kind of calm the spinning. Antihistamines you want to be careful with, because if taken too frequently, they can actually suppress the balance system so much that you can actually develop this 3PD, or the persistent postural perceptual disorder. So you see that a lot in patients. They'll have this chronic daily dizziness because they've been using these medications inappropriately. So I try not to use meclizine for that reason, or if I use diazepam or another benzo, then I make sure they're only taking it on occasion. So maybe once or twice a week, if that, but usually if they're having episodes that frequently, then we need to be a little more aggressive with the preventive treatment. Antiemetics like ondansetron and a lot of the others are effective. A lot of these patients do have nausea, and so important to treat that as well. We will try oral steroids if somebody's in just a really vicious cycle of vertigo. You can try oral steroids, dexamethasone, prednisone, to try and break that cycle. And then triptans are likely not helpful. So this was published back a year ago, but then there was also a Cochrane review published earlier this year that, again, they're likely not helpful. And we really don't know the safety of triptans in vestibular migraine. Neuromodulation, so I have a couple listed here. I know there are a lot more than this. There are some studies, some smaller studies that show that it may be effective as both abortive and preventative treatment. So I think it's, something to consider. You have to talk to the patient about it. Some downsides, it can be expensive, but if they're not tolerating the other medications, things like that, and again, because we don't have good abortive treatment, it might be a really good option. Sleep. I think sleep is a really important thing to focus on. We know that poor sleep can contribute to migraines. There was a study done in vestibular migraine, earlier this year that patients with vestibular migraine do have poor sleep quality, fragmented sleep, disrupted circadian rhythm. I will oftentimes check my patients for sleep apnea, or at least evaluate, symptoms. And then underlying anxiety and depression can contribute to poor sleep. So for these patients, amitriptyline might be a good choice, but again, you want to be careful if the patient does have sleep apnea. You don't want really sedating medications that can worsen that. So if I start amitriptyline, I try and make sure they don't have underlying sleep apnea or make sure it's well treated. So physical therapy. Physical therapy can be effective in these patients. It does not help with the acute episodes. So it's not going to help prevent the spinning episodes that occur, but it can help with that chronic daily dizziness that a lot of vestibular migraine patients have, that 3PD. So again, that's a central processing disorder. So the inner ears are working fine, the eyes are working fine, proprioception, all that. But usually the brain is relying too much on vision as opposed to the inner ear or vestibular input. And so vestibular therapists can help kind of retrain the brain to use the inner ears for balance. So my patients with chronic daily dizziness, I'll always send to physical therapy. It can also help with that, that motion and visual sensitivity. And then you want to consider, especially in older patients who might have other comorbidities, they can also have a chronic feeling of dizziness that's not necessarily 3PD. And this is going to be more imbalanced when they're up walking around. So when you combine imbalance with vestibular migraine, that's really going to increase your risk of falling. So important to treat, especially, like I said, the older patients who might have peripheral neuropathy or arthritis. All of this can contribute to proprioceptive disorders. Patients who are bifocal or progressive lenses, what that's doing is it's kind of blurring the peripheral vision, which we still need for good balance. So sometimes patients will switch to actually 2 different pairs of glasses, one for distance and one for reading, and they do a lot better. And then if there is any underlying peripheral vestibular disorder, so these patients respond well to physical therapy as well. Anxiety and depression, can't stress this enough. It's very important to address. You want to reassure the patient. You can't always see what's going on. The patient's feeling dizzy, but everything looks normal on the outside. And so that's really, really challenging. You want to reassure the patient that this isn't a psychiatric disorder. We see what is happening in migraine headaches, the same kind of thing that's happening in vestibular migraine. So reassurance is important. Treating the anxiety and depression can also treat the vestibular migraine, so amitriptyline, venlafaxine, propranolol, making sure they're getting restorative sleep, and then cognitive behavioral therapy. So again, treatment is very holistic. You want to look at the whole patient. You want to get the whole picture. What seems to be their main triggers? You use medication when needed. You want to look at the diet. So having the patients keep a journal can be really helpful. Decreasing stress, possibly treating allergies can help. And don't give up. So lack of response to even several migraine medications does not mean that the patient doesn't have vestibular migraine. And you can see there's so many different things to try. So I think we might be out of time for this. I was going to go through a few of the other disorders. I'll just go through it really quickly here. We already talked about Meniere's. Is it possible that it's a form of migraine? I know we are starting to treat Meniere's patients with migraine medications, even if they don't necessarily have a personal or family history of migraine, before we consider any of those ablative procedures. We'll treat them with migraine prophylaxis. 3PD, like I said, it's that chronic daily dizziness. I like to use venlafaxine in this. So 3PD is treated with physical therapy, SSRIs or SNRIs, and cognitive behavioral therapy. Of the SSRIs and SNRIs, venlafaxine seems to be the most effective in migraine. And so that's why I like it in these combination patients. Mal-de debarquement is a form of migraine. We do see there's a higher incidence of migraine in patients who have this disorder. So if nothing else, if they're not responding to physical therapy, I go ahead and try and treat them with some of the migraine medications. And then you can have a lot of other ENT manifestations of migraine. So patients who come in with chronic sinusitis, but their sinuses look totally clear, usually a form of migraine. You can have isolated ear pain and ear fullness with migraine, middle ear myoclonus or tensor tympani spasm. And then, you know, some of these smaller like case studies, a recurrent facial nerve palsy. So in practice, because there are so many different ways you can treat vestibular migraine, it's important to focus on just a few things at a time and kind of seeing these patients frequently until you can get things stabilized. It's important to have a lot of educational handouts, you know, because there's so much information, you can't cover everything in clinic. Having a way to get this information to the patients. And then if the patient is symptom-free, then, you know, consider trying to come off the medication. If they're open to it, you can always go back on. And then referring to the other providers, neurology, ENT, physical therapy, and all that. So that is all I have. Thank you very much. And I would love to take questions. And also, please feel free to email me anytime. I like to hear what works for other people and if you have any questions.
Thank you, Maria. It was a wonderful, beautiful presentation. You just walked us through the experience of a patient, listed all the practical difficulties usually we encounter when you see a patient with vestibular migraine. We have a few questions. One question, the first question is, in your practice, do you find vestibular migraine occur in a certain period of their lifetime, like during menopause? Our clinical practice, we see that it is during the extremes of ages, usually in children, younger population, and in the elderly population. What is your take on that?
Yeah, so we see it in all ages. I don't treat children, but you know, I know our ENT colleagues at the Children's Hospital right next door, you know, it's the most common cause of dizziness in childhood. See it in all ages. Yes, there is, you know, it occurs more often in women, especially women, childbearing age, middle age, things like that. But I'm treating patients even up to their 90s for vestibular migraine. So.
Okay. Another question, how does a patient typically present? I think you already elaborated in your clinical presentation. Usually it is a long-standing vertigo lasting 4 to 72 hours, and usually it is associated with classical migraine features like unilateral migraine, throbbing headache, and it has to fulfill the criteria of migraine, right?
Yes, so that is the criteria. Oh, sorry.
Yeah, no,
that is a criteria. I would say more often though, I will see patients who don't necessarily have those like the clear-cut symptoms. So a lot of times they don't necessarily have the migraine features with the dizziness. Some of the patients have never had a migraine. Actually, a lot of patients have never had a migraine. Oftentimes you don't have any headache with dizziness. So there's just such a wide range. Episodes lasting seconds at a time to days at a time. So many different presentations. And that's why I think it's really important to always keep in mind that it's a potential diagnosis for your dizzy patients.
Another question, can people have chronic vestibular migraine? Like chronic
Yeah, so that's a
migraine?
great question. Probably similar to, chronic migraine headaches. You probably can. I kind of wonder, is it chronic vestibular migraine, or is it that they've developed this 3PD, or the persistent postural perceptual disorder? And yes, I do see patients who have just chronic daily dizziness with this. And so that's when I will try and use venlafaxine or one of the SSRIs, SNRIs. Seems to be most effective in these patients.
Another question regarding occupational evaluation. Are there any occupational restrictions for patients with vestibular migraine? What is expected duration to return to activities?
Yeah, that's a really challenging one. This can be very, very debilitating. I think that's when it's important to get physical therapy involved, occupational therapy. They can really do a better functional assessment than what I can do. I think it's important to be able to give, if patients can't tolerate the fluorescent lights that you often see in office buildings, or if it's a computer screen, trying to target each one of those individually, and just working with the patient to see what they need. So yes, sometimes it does require some time off of work, or some modifications, like those blue light blockers, the glasses with the lenses that block the blue light. Those can be really effective for patients who need to work on the computer. So.
Another question, cervical instability affecting the vagus and upper cervical nerves. Can it be a factor for vestibular migraine? Vertigo per se, yes, we know, because the vestibulo-ocular reflexes are restricted to a certain extent because of the neck stiffness and all. Regarding the migraine also, is it the same?
I'm sorry, can you repeat the question? I missed the first part of it.
The question is, cervical instability affecting the vagus and upper cervical nerves. Can it be a factor for vestibular migraine?
I think so. Again, I think it's really patient dependent, but I think looking into that is very important. So the vestibular spinal reflex, the VOR, vestibulo-ocular reflex, all those can be affected in migraine. So a lot of it depends on, kind of the symptoms that your patient is experiencing. If it's more of a spinning sensation, you think that's somewhere along that peripheral vestibular, but if it's more this feeling of like just imbalance, then yes, you want to look more at that, the vestibular spinal proprioception, things like that.
Okay. Another question. Is there any correlation between migraine with COVID vaccination?
Yeah, I was looking into that a little bit last night. We definitely saw an increase in patients with dizziness, and then other inner ear things like tinnitus, things like that, after the COVID vaccine. I think some of it was hard to know, because I think patients were a lot more aware of their symptoms after the vaccine and just COVID pandemic in general. But a few things that I saw was there was an increase in migraine. So it's so hard to know cause and effect, right? This is a very stressful time. We know stress can increase migraine, so hard to know why there is that increase.
Okay. Another question, how long we have to keep the patient on oral medications?
Yeah, so again, I think that's patient guided. I think especially if they've had symptoms for years, I like to keep the patients on medication for about a year after their symptoms are stabilized. For some patients, they're comfortable with trying to wean off the medication once they've been stabilized for 6 months or so. So I think it really depends on the patient, but I think it's really important to get patients off medication when it's not needed.
Okay. Somebody has asked like persistent positional postural vertigo. Can you please re-explain that concept?
Which one? The persistent postural perceptual disorder?
Yes.
Yes. So that is the term that we use now instead of chronic daily dizziness or chronic subjective dizziness. So the way I think of it is like it's a central processing. So the brain isn't processing the information that it's receiving from the inner ears, the eyes, proprioception. It's not processing that information correctly. And kind of what I tell my patients after they've had a spinning episode, any kind of vertigo, it's almost like the brain doesn't trust the inner ear anymore. And so it starts to rely more so on the vision, which can be a problem.
I think you're not audible.
Oh, I don't know what happened here.
Yeah. Now we
Can
can
hear me now?
Yeah.
You can hear me. Okay. Where did it cut out?
When you started telling about the pathophysiology, the brain stores, yeah.
Okay, yeah. So the brain isn't processing the information from the eyes, the inner ears, and the proprioceptive input. It's not using that information correctly. So I think of it as when a patient experiences true vertigo, which is usually caused by the inner ear, it's almost like the brain stops trusting the inner ear and then relies more so on the vision, and which is a problem with gaze stability and things like that, visual triggers. And so it can cause this chronic feeling of dizziness. And so the treatment for that is kind of retraining the brain to use the inner ears appropriately for balance. So I think of it as like a central processing disorder of the balance input.
One last question. Is there any specific treatment for pregnant patients, or it is the same treatment for vestibular migraine?
Yeah, so pregnancy, definitely. I mentioned that a little bit with the valproic acid, but you want to look at all those medications and how safe they are in pregnancy, and also talk to the patient about what they're comfortable with. Make sure you're getting their OBGYN provider included. And you just have to weigh risk versus benefit. If the symptoms are so severe that the patient can't function, then yes, maybe you do want to use some of those prophylactic medications. If you can treat it symptomatically, that might be the better way to go. So it's so patient dependent, but just being familiar with what medications may or may not be safe is really important.
Okay. There were a lot of messages saying that awesome presentation. Thank you so much, appreciating your effort. So I just wanted to convey those messages to you as well. It was a wonderful presentation, Ms. Maria. Thank you so much.
Thank you. Thank you for having me.
So now we will move to the next session. It's on CGRP treatment in migraine. Our next speaker is Dr. Kalin Jedan. She's a consultant neurologist in Mediclinic Airport Road Hospital. She graduated from Lebanon, from University Saint Joseph Hotel de France. She has a subspecialty in critical care neurology from Paris, from Salpêtrière Hospital. She also had a training and fellowship in neurophysiology and epilepsy. She had been practicing in Lebanon in various university hospitals as a consultant neurologist with special interest in critical care, neurology, stroke, EEG, and epilepsy. And she was a faculty in the medical department as an assistant professor in Belmont University in Lebanon. Now she is with us, and tonight she will be speaking about the CGRP treatment for migraine. Welcome, Dr. Kalin. It's my pleasure to.
Thank you, Doctor. It's my pleasure to be with you, and thank you for the kind introduction. Without further delay, I will share with you my slides. So I don't know if the audience is familiar with the rimegepant. Today we will be discussing rimegepant as both an acute and preventive treatment for migraine. And this was a huge leap in the recent years in terms of migraine treatment, having a treatment that works both as an acute and preventive medication. So these are my disclosures. So usually when we want to judge if a treatment is good enough for migraine, upon judging an acute treatment, we measure many indicators. So one of the indicators would be rapid pain relief. We wouldn't want an acute treatment after which we would have to wait a few hours for the drug to kick in. This won't work for migraineurs. Second, we would love to have sustained pain relief, because it won't work either if it gives us partial relief or short-lived relief, and then a few hours we will have to repeat dosing over and over to get through the day. So a good acute treatment should minimize the need for rescue medications and the need for repeat dosing. And then usually we judge not only by the relief of pain or the freedom of pain, but also by the relief or freedom of associated most bothering symptoms. Because as we all know, migraine is not just about the headache, but sometimes the associated symptoms are more bothering or even as bothering as the migraine, like photophobia, phonophobia, nausea, etc., sensitivity to light, to sound, etc. And then when we have, or if we have a good acute treatment, it should optimize the self-care. So patients would manage themselves their migraine, and therefore we would reduce the use of resources such as ER visits, multiple brain imaging, OPD visits, etc., and therefore reduce the cost, the public health costs in terms of resource use for migraine patients. So usually these are the indicators to judge if an acute treatment is effective or not. And last but not least, it should be a safe drug with a tolerability profile that is acceptable. Because if a drug is effective at the price of side effects, it wouldn't be a good bargain either. So at the end of these slides, you would be able to judge if rimegepant is effective or if it's a good acute drug. But rimegepant raises the bar because it presents itself also as a preventive treatment. And how do we judge a preventive treatment for migraine to be a good one? Usually by many indicators also. First, it should reduce the monthly migraine days. So the number of days spent with migraine should decrease with a good preventive medication. And usually a good indicator in studies would be the 50% decrease in MMDs. Second, it should also reduce the intensity from, for example, moderate to severe intensity pain to mild to moderate tolerable pain. And then by achieving these two, we would be achieving or optimizing recovery of normal function, and then improvement of quality of life. And all these indicators would contribute in decreasing the overall migraine burden for migraineur. So we will be discussing all these indicators as rimegepant presents itself as both an acute and preventive medication. So rimegepant belongs to the class of the gepants. As we all know, the recent years showed that CGRP is a main actor in the pathophysiology of migraine. And so by inhibiting the CGRP, whether it is on the ligand level or on the receptor level, we would be acting in a targeted way on the migraine. So gepants are small molecules that have a high affinity in binding to the CGRP receptor. They competitively bind to the CGRP receptor, therefore inhibiting the action of CGRP on its receptor, and therefore acting in a targeted way on migraine. So till now, we had triptans as the mainstay of treatment for acute medications, and we had repurposed drugs as the mainstay of treatment as the mainstay of preventive treatment of migraine. And we will discuss the differences between these types of medication and rimegepant later on. So to demonstrate the efficacy and safety of rimegepant, many clinical trials have been conducted. We have 4 phase 3 studies that have validated the efficacy and safety of rimegepant in acute treatment, which we will discuss 1 or 2, and we have 1 phase 3 study that validated the efficacy and safety of rimegepant in preventive treatment. So now we will be discussing first the study 303 regarding acute treatment of migraine, and then we will be discussing the study 305 for the preventive treatment of migraine. The study 303 that assessed the efficacy and safety of Nurtec for the acute treatment of migraine randomized patients into 2 arms of either placebo or rimegepant with more or quite similar characteristics in terms of mean age, in terms of gender, in terms of primary migraine type, mean duration of untreated attack, mean number of MMD, and associated most bothering symptoms. And as you can see, the numbers are quite similar, so the population characteristics were quite similar. The co-primary endpoint that was tested was freedom from pain and freedom from the most bothering symptoms at 2-hour post-dose. So this is the main indicator usually to judge an acute treatment efficacy. And in terms of freedom from pain at 2-hour post-dose, I'm sorry, I lost the slide is buzzing. Okay. So in terms of freedom of pain at 2-hour post-dose, rimegepant achieved 21% versus 10% in the placebo arm. And the freedom of most bothering symptoms, whether it is photophobia, phonophobia, nausea, etc. And this was reproduced for any of these MBS. There was an 8% placebo-adjusted difference. And for both outcomes, the p-value was highly significant. Rimegepant provided significantly better freedom from pain starting 1.5 hours post-dose compared to placebo. And as you can see in the graph, this was attained at the highest level at 2 hours post-dose. And therefore, as a secondary endpoint, we tested if there was a sustained pain freedom and reduced use of rescue medication within the first 24 to 48 hours, because this is a major indication when judging the efficacy of an acute treatment. So rimegepant achieved significantly sustained freedom from pain between 2 to 48 hours. So it conferred freedom from pain up to 2 days after the migraine attack and up to 2 days after the first dose. And it reduced the use of rescue medication within 24 hours with also a significant p-value. With rimegepant, patients experienced rapid pain relief up to 2 hours as well as sustained pain relief. So this is another secondary endpoint, because sometimes it's very hard to achieve pain freedom, meaning zero pain for patients. Sometimes the patient takes a pill for a very severe migraine, and just a partial pain relief is very acceptable for him to go through the day, to regain average functionality at work, not to miss working hours, etc. So when we talk pain freedom, it's achieving zero pain, and we saw earlier on the numbers that rimegepant achieved. But when we talk about pain relief, meaning decreasing the pain intensity from moderate to severe intensity to mild to moderate intensity, and here, as expected, we will have much higher proportions. So pain relief with Nurtec compared with placebo at 60 minutes, 90 minutes, and at 2 hours showed significant difference. And this result was sustained during the first 24 and even up to 48 hours after dose. So we go to the next indicator of efficacy. So after pain freedom and pain relief, after sustained pain freedom and pain relief, this gets us naturally to the recovery of function. So rimegepant significantly improved the ability to function normally at 1 hour post-dose and sustained this normal function compared with placebo. 26 versus 15% with a significant p-value. In terms of tolerability, the tolerability profile of the rimegepant was close to placebo, and the liver safety study showed nearly no difference between rimegepant and placebo. There was only one subject in each treatment arm that had elevation of ALT, AST more than 3 times the upper limit of normal. A post-hoc analysis showed that Nurtec significantly showed a significant difference from placebo in freedom from pain and most bothering symptoms at 2 hours, regardless of previous triptan use. And this is very important because usually the first question that the patient asks us, for example, he says, okay, I tried 2 triptans before, I tried 3 triptans before, it didn't work. Why would such a treatment work for me? And usually we should have solid ground based on clinical trials to answer this patient. And this clinical trial included patients who were either triptan naive, or on current triptan use, or patients who failed previous triptan medication, whether it was 1 triptan or 2 or more triptans. And the results were very satisfying, and there was a benefit from rimegepant regardless of the population arm. So regardless if the patient was triptan naive, treatment non-responder, or multiple triptan non-responder, or triptan failure due to cardiovascular side effect, etc., rimegepant showed benefit and efficacy regardless of previous triptan use. It's because the pathophysiology is completely different. In fact, the rimegepant targets the CGRP, so by binding to its receptor, and therefore it would act on migraine in a targeted way, whereas the triptan use, the triptans, they would target the serotonin receptors, mainly the 5-HT1 receptor, whether it is the 5-HT1B on blood vessels, where they would cause vasoconstriction, or the 5-HT1D on the nerve endings, where they would cause decrease in secretion of vasoactive peptide, and amongst those would be the calcitonin gene-related peptides. So the pathophysiology is different, and failure to triptan will not mean at all a destined failure to rimegepant. This is the first difference. The second difference between triptans and rimegepants would be mainly the cardiovascular risk profile, because as I explained, the triptans would act on blood vessels and provoke vasoconstriction, and therefore they are either not advised or even contraindicated in patients with high-risk cardiovascular profile, whereas gepants, by acting on CGRP, they will prevent the vasodilation that is caused by the CGRP without causing the counteractive vasoconstriction. And this is very important because this is a huge benefit of gepants over triptans in terms of cardiovascular side effects. And last but not least, the most important difference between gepants and triptans, one of the most important would be the possibility of medication overuse, because with excessive use of triptans, we would have downregulation of serotonin receptor and therefore central sensitization and chronification of migraine by decreasing the descending inhibitory pathways of pain. And this mechanism was not found in gepants. So gepants do not cause medication overuse headaches. So these are three benefits of gepants over and rimegepant over triptans in terms of acute treatment. So this is a typical case scenario for Muhammad who comes seeking an acute treatment for his migraine. This is a 55-year-old engineer who has been having a long-standing hypertension, obesity with a BMI of 34, and who was recently diagnosed with diabetes type 2. He has a 30-year history of migraine with aura. At presentation, he was having 3 monthly migraine days that reduced from previously a value of 8 on a previously prescribed preventive treatment. So we are facing a low-frequency episodic migraine. His current treatments are candesartan for the hypertension and zolmitriptan for the migraine as needed. Zolmitriptan relieves the headache, but he has frequent recurrences requiring multiple retreatment during the day or during the week. So this is a patient who has multiple risk factors and that are hypertension, obesity, diabetes, and he has a migraine with aura, where the cardiovascular risk factor would be higher if we use a vasoconstrictive treatment. Second, it's a patient who is having very partial relief with triptans with high need of retreatment and repeat dosing. So what we did is we switched his acute treatment to Nurtec because it's not a vasoconstrictor. It's safe in terms of cardiovascular risk profile. It addresses the concern about cardiovascular precautions with triptans, and it has approximately 11 hours half-life, which makes it confer sustained pain relief and sustained pain freedom up to 24 to 48 hours and minimizes the need for repeat dosing. And these are the main indicators that we spoke about at the beginning of this talk. So these are the take-home messages regarding rimegepant in acute treatment of migraine. Now we go to the preventive treatment of migraine, and this study assessed the efficacy and safety of Nurtec for the prevention of migraine. So it is also a phase 3 randomized double-blind placebo-controlled study with population characteristics that are very similar between the placebo arm and the Nurtec arm. It included adults aged 18 years and above with more than 1 year history of migraine with or without aura. And after a 4-week observation period, eligible participants were randomized to either Nurtec or placebo. The primary endpoint was the change in NMD from baseline during weeks 9 to 12. So this is the decrease in MMD. There was a significant decrease in MMD in Nurtec arm versus placebo with a highly significant p-value. And here you may see that in terms of number of days, maybe it is not very huge, but for us, these are days that are that we are giving back to the patients. So when a patient, for example, goes down from 8 mmD to 5 mmD or to 4 mmD, it's huge for him because he won 4 days of his months. And then these days he would assist in activities, in family gatherings, etc. So these are days that are given back to his social life, his work life, and his productivity, his productive days, etc. So here we showed a significant decrease in MMD versus placebo. And when we tested the 50% reduction in MMD, there was also a significant difference between the Nurtec arm and the placebo arm with a highly significant p-value. So when we reduce the MMD by half, you are doubling the days where the patient is functioning normally, living normally. And this is a very high achievement for us. Moreover, efficacy was sustained for up to 1 year in the open label study extension period, meaning that there was no wearing off effect. So there's no honeymoon period where the patient comes, says, yeah, everything is all right. And then 2 months later, he says it's not working anymore. Because for some other drugs in preventive treatment, there has been shown a wear-off effect or a questionable wear-off effect. The safety and tolerability of the Nurtec in the study 305 was also compared to placebo. The liver safety results showed low rates of increased enzymes in both treatment arms. And similar proportion of patients, nearly 1%, had ALT or AST increased more than 3 times the upper limit of normal. Only 1 patient in the Nurtec group had asymptomatic aminotransferase elevations, and these mainly were for ALT. Alkaline phosphatase and bilirubin levels were always within normal limits. So to sum up the take-home messages concerning the preventive treatment, this is the case of Aisha. She's a 30-year-old recently married woman who has migraine without aura, up to 14 monthly migraine days. She returns to clinic because she's planning to get pregnant in the current year. She was started previously on CGRP, on injectable CGRP inhibitor over the last 6 months, and she improved clinically. And now she has 3 migraine days without aura per month. She is usually relieved by sumatriptan as an acute medication as needed. And she has some breakthrough headaches, usually triggered by stress. So what are the considerations? The CGRP inhibitor that she is currently taking, the monoclonal antibody. These monoclonal antibodies, they have a very prolonged half-life. And what we know is that for a drug to be nearly totally eliminated from the body, it needs what's equivalent of 5 half-lives. So if the half-life is up to 28 days, it will need around 5 months to be completely removed. And usually what we advise is to stop the monoclonal anti-CGRP 6 months prior to planned pregnancy. The safety in pregnancy is unknown. There has been some registries in Europe, but till now we don't have data from a randomized controlled trial or from a reliable trial done on pregnant population. In this case, we will need to discontinue the injectable CGRP receptor and replace it with treatments that would have a much shorter half-life to expedite the washout in case of pregnancy. And viewing that this patient has documented to be a CGRP responder, viewing that she responded to the monoclonal CGRP inhibitor, therefore she is a responder to, she's ought to be a responder to rimegepant. So what we did is that we switched her to rimegepant because it has a short half-life in terms of quick elimination when needed. So we discontinued the CGRP inhibitor, the injectable. We started her on Nurtec. The transition was not associated with headache exacerbation. So usually the transition is smooth for patients, and we achieve control over migraines quite rapidly. Nurtec was also used as an acute treatment for her breakthrough headaches because, as we know, when it is used as an acute treatment, it is used as needed. Usually, we recommend not to repeat the dosing during the 24 hours, and usually they won't have the need for the repeat dosing. But as a preventive regimen, it is taken every other day with a maximum limit of 15 tabs per month. But the efficacy studies showed that we can go up to 18 tabs per month, which offers the patients up to 3 tablets that can be used as needed for breakthrough headaches. So this is the summary of everything that we explained. The contraindications are usually hypersensitivity to the active substance, the usual. And we must be cautious when using the rimegepant with the CYP inhibitors or CYP inducers because the plasma concentration of rimegepant would differ accordingly. So as a take-home message, Nurtec demonstrated early and sustained efficacy and was well tolerated in terms of safety in the acute treatment of migraine in adults, but it was also effective for episodic migraine prevention in adults, significantly reducing MMD from baseline compared to placebo. Treatment with Nurtec every other day was well tolerated compared to placebo and was not associated with any unexpected or serious safety issues. And with that, I thank you for your attention and I'm ready for your questions.
Thank you, Dr. Kellen. It was a wonderful presentation. You have detailed the whole pharmacokinetics, pharmacodynamics, and the clinical experience with respect to Nurtec. Yeah. With regarding to I think GPANs are the wonder drugs for migraine because you can give it as preventive therapy and as abortive medication as well. So for episodic, low frequency episodic migraine, it can be a solo therapy. And chronic migraine, it's an essential therapy because with other medications, definitely we'll end up giving it.
It is an ally for neurologists
Yes.
when treating migraine. It is a strong ally.
Yeah. With respect to the vestibular migraine, what is your experience? Like triptans, patients with headache, they take triptan, the headache subsides, but it leaves them with severe vertiginous episodes. I had one vestibular migraine patient. I gave rimegepant. there was a mild improvement in vertigo, but I don't know because it was a one-time event. So not sure whether it's just a one-time event or it is really an effectiveness. What is your clinical experience with respect to this? Sometimes one of the most bothersome symptom of migraine can be vertigo as well.
Dizziness.
What is your
In
experience?
fact, in terms of triptan use, dizziness is a confounding factor because it's a frequent side effect of triptans. So patients who would tell you the headache subsided, but I had dizziness. So maybe it's not the dizziness related to migraine, but the dizziness as a side effect to triptans that they were having. And this is where we benefit from Gepants and mainly rimegepant because even if it was not studied on this specific subpopulation of migraine, nothing says or nothing discourages us from using it in migraine, in different subtypes of migraine, because it was tested on different populations, on migraine with aura, without aura, high episodic, low frequency episodic, cardiovascular risk profile, concurrent use of triptan, etc. So viewing that, it proved efficacy in very diverse population. Nothing discourages us, at least, from using it in vestibular migraine. To be honest with you, vestibular migraine is not all over the roads.
Yes.
We've had a few cases, and I wasn't reluctant at all to use the rimegepant, and there was benefit as expected. But I cannot give you percentages because I did not conduct a study on it. But for me, it was as effective as expected.
Thank you, Dr. Kelly.
Without the confounding factor of triptan side effects. So you can judge that there was dizziness or not because it's not a side effect of Nurtec as it is in triptan.
And elderly patients also, it's quite safe to give the Gepants because most of them, they have comorbid gastrointestinal issues and all. We are worried to give, for diabetic patients, we are worried to give the NSAIDs, triptans, we are worried to give because of the cardiovascular issues. Nurtec, it solves all those problems. So it's altogether a
Exactly.
question. There is a question, can I repeat the sumatriptan more than 3 tablets within a month, 100 milligram?
Within a month, yes, but within a day, I'm usually very cautious with triptans. For me, these are drugs that offered acceptable benefit over the years. We must admit that over the years, we didn't have anything but triptans. So it offered an acceptable benefit, but at the price of tolerability and side effects and cardiovascular side effects. So usually I'm very cautious in using triptans, and usually I give patients 2 possibilities of acute treatments. I give them the possibility of a potent NSAID or a potent analgesic for mild to moderate headaches. And then I tell them that you can use the triptan only for severe headache and try not to repeat the dosing during the day. This is my way of dealing with things because I'm very cautious with triptans, and I wouldn't be very generous prescribing repeat doses of triptans.
Another question.
But during the month, yeah.
Yeah, you can carry on. No, we have one question. We can wait. No problem. Tell us.
Yeah, it's okay. I'm done. Tell me.
What are the drug interactions of Nurtec?
Mainly CYP inhibitors and the CYP inducers. So, for example, antifungals, etc. So, for the vast majority of the usually prescribed drugs, for example, the antihypertensive, the antidiabetics, etc., there won't be any issue. But just when you have an uncommon drug, an antifungal, something of the sort, just check the interaction list to make sure it won't interact. So the interactions are really limited.
Thank you very much, Doctor. I think it was so nice that that Pfizer chose these two topics, much debated, and usually it is a fragmented session, one for acute treatment and for preventive medications. It was nice that you combined both, because it's difficult to separate. Like it's part of the spectrum usually. So
yeah, and usually when a drug enlarges the spectrum of indication, they lose a lot on the way. So that's why I stressed in the first place on the many indicators when we judge an acute drug and when we judge a preventive drug. And the rimegepant showed efficacy in all these indicators in terms of acute and preventive treatment. So this is very pleasing for us neurologists.
exactly. Another question, what are the prophylactic medications during pregnancy? I'm reading out the questions from the audience.
So concerning targeted therapy, the monoclonal antibodies are contraindicated even when planning pregnancy. So if a patient may have unexpected pregnancy or is planning for an upcoming pregnancy, it is advised to discontinue the monoclonal antibodies minimum 6 months. The leaflet says 5 months because it's 5 half-lives. But for us, we say 6 months prior to planned pregnancy. So unfortunately, we cannot use any of the targeted treatments. Rimegepant would offer a benefit, and gepants in general would offer a benefit because of the rapid clearance. So if ever there is an unexpected pregnancy, it is cleared within days, so there is no safety concern in this. But concerning other prophylactic, if we go back to the usual or the classical repurposed drugs, none of them is approved in pregnancy, except for the European registry. They approved the amitriptyline use in pregnancy. So because I did my studies in France and I followed the European registry and the French registry for teratogenic agents, the French registry approves the use of amitriptyline during pregnancy, but this differs from a country to another because we have an audience from different countries. And usually the last decision maker is the gynecologist. So usually we advise the patient to take the final okay from the gynecologist, but usually triptizol or amitriptyline is quite safe in pregnancy at low doses. Otherwise, paracetamol.
One last question.
Yeah, but Dr. Pourmani, if you allow me, I have a question for Dr. Kaleen.
Sure.
First of all, Dr. Kaleen, thank you so much for this excellent presentation.
Thank you.
And very insightful discussion. It's always our honor to have you. I have a question regarding this challenge MIG trial that compared galcanezumab to rimegepant. Yeah, so and how this will change our practice as clinician with the prescription pattern of rimegepant in the treatment of episodic migraine specifically.
So galcanezumab is for me the gold standard up till now in the preventive in targeted preventive medication for migraine. So it's a very potent monoclonal anti-CGRP, and I always say that rimegepant, as the most recent drug in migraine treatment, made a huge leap in showing non-inferiority or equal efficacy against this gold standard that is the galcanezumab. And this makes a huge switch in our clinical practice because patients would, for example, a high number of patients would prefer not to have injections and to come monthly for their injection by the nurse, etc. And they would prefer just a tablet on their tongue. So now we are having the same efficacy in terms of targeted preventive treatment of migraine with an increased facility of use for the patients. And this is one of the indicators for the migraine treatments that I stated earlier, is to optimize self-care and minimize the use of resources. So when a patient manages his migraine himself, whether it is on the acute level or the preventive level, first of all, it improves his quality of life, and it improves the facility of the treatment, and it reduces the resource use in terms of OPD visits, nurse visits, etc.
I think
And we
another
have
thing is, if you allow
Yeah.
me to add, I think
Yeah.
another thing is with injectable medications, they recommend 1 year to 18 months. And after that, when you stop, there is always a rebound. So always that question, and migraine, there is no cure. So always it remains. So always the patient is apprehensive, like how long they have to continue on medication. So with respect to Rimicipan, that is the advantage. When you have a rebound, you take the medications PR and as and when
For
required.
the breakthrough, yes.
Yeah. So that question of how long doesn't matter anymore.
But the rebound effect is not very common with the injectables, because mainly for me, in my experience, I concluded that it depends where the patient is. If you have a very severe patient that tried a lot of medications before getting on the injectable, a patient that required an injectable plus botulinum toxin plus, for example, low dose of amitriptyline. So this is a very, very complicated patient. We would definitely expect rebound recurrence or worsening of headache upon stopping the injectables. But if a patient has episodic migraine, he was on only injectables, and he went to zero migraine within a month or two, usually after a 1 year of treatment, we tend to conclude that after 1 year or 18 months of treatment, when we stop this treatment, the benefit is still there for many months to come, for at least 6 or 7 months to come. So usually it is a sustained benefit. But if there is a rebound effect, as you said, Nurtec is a great addition for breakthrough headache and for rebound worsening.
Invariably, after some time, they will have headaches because there is no cure for migraine.
Yeah, you are right. There's no cure. It's just a sustainable benefit. Yes.
I think we are done with our questions. And I thank Pfizer for organizing such a wonderful evening with great speakers. I thank Dr. Callie. And although Ms. Maria is not with us, wonderful presentation from her as well. I thank her, Ms. Maria. And hopefully we'll be coming up with new upcoming activities in the field of neurology and neuropsychiatry. Thank you very much for having me here as well. Thanks a lot, Faisal, and good night.
So just thank you, everybody. Thank you, Dr. Kalin Jaddan, for accepting our invitation and always be our guest speaker. Thank you, Maria Mashallah, also for joining us all the way from the United States, despite the difference in time. And thank you, Dr. Purnami, for this excellent moderation of the webinar. Also allow me to thank our collaborator, the American Migraine, the Association of Migraine Disorders, and our sponsor, Pfizer. So thank you all for supporting us. And of course, the big thank you goes for our attendees, for they were numerous today, and for staying with us tonight until the end of this webinar. Allow me to remind you that you will receive your certificate of attendance by email within 1 week of today. Also, if you missed any part of this webinar, or you would like to revisit the lecture of Maria and Dr. Kalin, you can always visit our IVPN library, where all the recordings of these presentations will be posted. And actually, access to this IVPN library is free of charge. Don't forget also to follow us on our social media media platforms. So keep your eyes on our LinkedIn IVPN NeuroPsychiatry page, where all our upcoming educational activities will be announced. Our next activity is scheduled in December 18, and will discuss management of headache in the emergency department. So stay tuned for another successful migraine masterclass. And until I meet you again, have a good night, everybody. And thank you so much.
Thank you. Night.
Bye.
Thank you.